Good afternoon. Welcome to this first aortic session. I have the honor of animating this session with my good friend Gustavo Oderich from Houston. We are going to focus on the ascending aorta and the arch. And the first question for you, Gustavo, off-the-shelf single branches for the arch. What's the durability and complication of bypasses? Thank you, Gustavo.
Thank you, Stefan. Thank you for having us here in Paris, such a great venue. Really raising the bar for these meetings. And I appreciate having the chance to be here. These are my disclosures. There are a number of advantages of single branch device. Of course, there is also a number of disadvantages. One of them is the mere fact you are now having to do a component of open surgery, of surgical debranching, and dealing with the potential complications of that. There is really a couple of players on this area currently. The Nexus endospan device is investigational, at least in our part of the world, but there's some preliminary data on earlier experiences, as you can see here. For us in the US, the reality is that this is the only commercially available branch device. The Gore TBE was launched in August of last year, and it quickly ramped up the volume to over 1,000 cases in the first year of experience. You can see here the distribution of the larger volume centers in the US. Now, we know actually not a lot about cervical debranching for aneurysmal disease. There is a little bit of literature for occlusive disease. It's not quite the same. As you can see here, the patency at 3 years was 88%. We're talking patients with atherosclerotic disease, tachyarthros, vasculitis, etc. These are commonplace operations on our practice, and actually, I would say extremely important for vascular surgeons and cardiac surgeons to know how to do these operations well. Carotid subclavian bypass and transposition, they share similarities in terms of surgical exposure, including the fact you have to deal with a number of nerves, in particular the phrenic nerve, but also the vagus nerve. And then carotid reconstructions with prosthetic also are part of the armamentarium. It can either be done with a pretracheal tunneling. My preference is for a retropharyngeal tunneling, which, you could argue adds the potential risk of dysphagia. Having said that, I have not experienced this complication. But there is a number of early problems we have to be aware. These operations are fraught with the need of more dissection in a patient that is systemically heparinized, that carries a risk of hematoma postoperatively, of wound infection, and by trend also graft infection. Cranial nerve injury, phrenic nerve injury in particular, as you'll see, is a major issue if you're working on the left side, chyle leak. If you're doing a transposition, the risk of Horner syndrome I found to be not a negligible problem. And of course, these are very fragile vessels. The subclavian artery, I will say, akin to a pulmonary artery, is extremely thin wall, and you have to be gentle how you do that anastomosis. I also found that jugular vein thrombosis is frequent. If the critical care team does screening ultrasound after these patients have the procedure, oftentimes they find some thrombosis. In terms of recent literature on carotid subclavian bypass, I point out to this paper, in particular, the fact they found a 25% rate of phrenic nerve injury. And actually, that goes often unnoticed, and that will be that patient that is younger and a little more fit that will complain to you in the office that they are having, some shortness of breath that was not present before the operation. Now, granted, some of these are reversible in the first month. Having said, the patency of these bypasses or transpositions is really outstanding and far surpass what we've known in the past for occlusive disease. The Hamburg team has done a recent review on a large experience with cervical debranching. As you can see here, local bleeding complications is a major issue. 1 out of 10 patients was affected by that. And again, the risk of infection it can be a problem, in particular graft infection. I'll show you one of my cases, but the patency rate is outstanding. This is a patient I actually did a thoracoabdominal repair and cervical debranching procedure, and you can see the patient developed a localized infection in the left carotid subclavian anastomosis that we were able to cool down with antibiotics, and so far have not had to do a full explant of this graft, but certainly that will be a major challenge if you have to do it. And this is another case that actually happened during the trial. Right at the end of the operation, we've noticed the arterial line flattened, and I immediately reopened and did an angiography to find out there was a innominate artery dissection with a complete occlusion of the carotid artery and the entire inflow to that graft. Fortunately, the patient had a large vertebral artery that fed the entire brain, and I reopened the neck incision, removed the plaque, passed a wire through the true lumen, and then excised the plaque, put a patch in the carotid artery, stented the inflow, and this patient recovered with no neurodeficit. But that shows the issue of having the entire brain dependent in a single branch. The TBE trial started with an early feasibility phase. The results were actually outstanding, in particular for zone 2. There's very small numbers for zone 0. And in fact, the data on the longevity of this cervical debranch bypass has not yet been published. Having said that, for zone 0, the retrograde branch performs very well with a patency up to 5 years, you can see here, of 95%. And in fact, the pivotal study has also been published from zone 0, and a remarkable number of patients have been enrolled. This is a prospective study now with nearly 300 patients enrolled. We are still waiting the analysis for zone 0, but you can see here the core lab adjudication for zone 2, that the patency has not been a problem all the way to 1 year, as well as the rate of type 1 and 3 endoleak. That's mostly in the first 30 days, and then it resolves, but there is certainly a rate of that. And you can see here for the dissection cohort, which is one of the main utilizations of these devices. We learned for dissections, that's also an issue. We still will need to do single vessel reconstruction with cervical debranch. No matter how developed these branch endografts become, there are some patients that have bad anatomy for stenting. They have extensive dissections, perhaps an early vertebral artery origin, or thrombus that you don't want to stent. This is an example shared to me by Nikos, who is here in the panel today, of a case that he had to do embolization around the stent to deal with this endoleak. So in conclusion, single branch devices offer an off-the-shelf solution. I think that that's very important. Also, it might be easier in the future if we have a good filter device to deal with a single branch than actually 3 branches. But the morbidity of these cervical bypasses is not negligible. Phrenical nerve injury I found to be a big deal, hematomas requiring evacuation, and other wound healing complications. One of the advantages is patency that is superior to occlusive disease. Thank you very much for your attention. It's a pleasure to be here today.
Gustavo, thank you very much. And I'd like to kick off the discussion by asking you, you quoted the hematoma issue, 11% of patients. It seems to be even more in our daily practice. How do you deal with the heparin at the end of the procedure? And what is your level of ACT during the procedure? And do you inject protamine at the end? And I'll be happy to have Andrea and Nikos' experience.
Well, I agree with you, Stefan. I think if I, for some reason, decide to do a full arch with a carotid subclavian, I like to stage that. I don't like to do it in the same day as the endovascular segment. For a carotid subclavian, I don't mind. It's a relatively limited operation. It goes very fast. But for the full debranching, you're doing bilateral cervical incisions. I think meticulous hemostasis is key. And you're right, if you mix that up with the endovascular part, you end up having some complications. And that's what we experienced with the 3-vessel arch in the series we did together where we were doing bilateral cervical incisions, is that hematoma requiring evacuation was one of the most frequent indications for secondary intervention.
Yeah, and that's why we moved to a complete PERC approach to avoid that. Nikos, Andrea, do you want to comment? Can we have the microphone on stage, please?
Yes, I found I'm usually working when I do extracranial bypass with extraanatomic reconstruction, bilateral incision, usually stay between 200 and 250 of ACT. usually always perform protamine after intervention. And in recent times, we avoid to use Daikon grafts, but only use PTFE because of the bleeding within the fabric. It was a problem.
Interesting. I actually do the opposite because of needle hole bleeding with PTFE. So my preference is usually to use Dacron if I decide to do a cervical debranching, quite frankly.
And if you use ePTFE, then maybe you use the specific
future
ePTFE.
Yeah, the Gore suture.
Yeah. Okay. Nikos, any?
So our experience is, the paper you cited was actually from our experience, and I agree that bleeding complications is an issue. Nerve injuries is probably, with more experience, not such an issue, but in bigger institutions, I would say it's very common that one surgeon does the carotid subclavian bypass and another one sometimes does the more complex endo repair. And there is a learning curve there, for sure. What we have done is a little bit in our technique change that we always do. I don't remember when I did a carotid bypass last time, to be honest. I think that is in our practice in Europe, where we have also for the emergencies, the double arch device or the triple arch device quite out. But with the carotid subclavian bypass, it changed a little bit something in my practice when I regularly did the subclavian anastomosis first, because I think many of these bleedings are little bleedings that come from the toe, from the beginning of the anastomosis in the inner part, where you don't note if you do the carotid anastomosis first. I don't know if you share that experience.
Sure. I think staging is key. Any question from the floor? You guys are sleeping after lunch. That's good. I think we have all tried to move, except in emergencies, to staging those procedures to avoid those complications. So having in mind all the data you showed, what is the place for a single branch device, and what is the place for a double or triple branch device?
So I think, Stefan, of course, is a lot of what we do nowadays is what's available in your country, literally. Regulatory approval is a big part of it. So right now, the reality is that's the only device available. But, you know, let's say in a foreseeable future that we have all choices of single, double, and triple. I think that being off the shelf, that's going to be a part of it. There is certainly for Zone 2 very good data with now multiple companies showing retrograde branches is, despite some initial concern with the configuration, actually performs quite well. And I think that unless we have truly a double, triple arch branch device that is off the shelf and available, you know, which I think is quite a ways to go, quite frankly. Even though it can be done, it's still not there, at least in the United States. You know, the single branch is going to be needed for the urgencies, the cases that are symptomatic, that we can't just wait.
So that's why it was very important that you showed all those data and technique. Thank you very much, Gustavo. Big round of applause for Gustavo. And Nikos Tsilimparis from Munich, Germany, will talk now about complex aortic arch endografting using a transapical wire. Thanks, Nikos.
Thank you, Stefan, for this amazing venue and this amazing meeting again. Very honored to be here. And the topic is, of course, a little bit not our everyday practice, but a tool that could be very useful in certain cases that we cannot move forward. This is what we like doing more and more nowadays when we have the complex anatomies with triple arch devices. And the way we do it standardized right now is an evolvement of the technique that Stefan and Thilo and others have presented, where we do first over a transaxillary approach, the first branch, and then instead of cannulating from above, we do the reverse branch for the left carotid using the through and through and through wire technique, and therefore doing an antegrade cannulation of the left carotid artery from inside the graft, and therefore avoiding the exposure of the supraortic vessels. However, we all know that there are anatomies like the one you see here, where the tortuosity of the thoracoabdominal aorta, including the presence of multiple stent grafts, will make the advancement of any endograft very, very challenging. So what can we do in such cases? And we know from the experience of cardiac surgeons that the transapical access is, of course, not the routine access. Also for the TAVR procedures is more an alternative way to go. But it is a useful thing to have if you need to have a wire that takes you all the way to the left ventricle. So the way the cardiothoracic surgeons do it is through an anterolateral mini thoracotomy. They use 2 big sutures or 3 sutures at the myocardium, and they therefore manage to get access into the heart, into the left ventricle, thereby making sure that you have a secure direct access through the heart. There are, of course, limitations, and they have seen that in their studies, which involve mostly the scarring of the tissue, ventricular ruptures that have been observed, and the secondary bleedings that can also lead to tamponade. So this was a case that we had with this challenging anatomy with multiple angulations in the thoracoabdominal aorta, thoracic endografts, abdominal endografts, iliac side branches in these cases. So this patient was not quite friendly for an arch branch device of 24 French size. And we tried to go in with the regular way that we would do it. Perhaps move to the next bookmark, please. And we were able to, we were trying to find ways on how to move this graft all the way up. One big discussion point is, do you really proceed to treatment with such a patient? And this is something that is open to discussion. When are the limits that we should pull? This patient also had, on top of everything else, prior bio-valve. So we tried to go up in the regular way using the typical techniques here, for example, using a second Lundaquist, which in my experience has never helped me really, but it's described in every textbook that you can find. Of course, that led us only up to the most critical point, which is that edge, and the wire was still not in the left ventricle. So we're stuck there, and now it's the question how we move forward. Well, in this triple arch device, there's always an accessory, there's always this preloaded catheter, which is actually meant for the left carotid artery, for the left subclavian artery. So we try to snare a wire there and see if we can pull that in order to bring the graft around the corner, but that didn't work either. So the next step was to go together with our cardiac surgeons and create a through-and-through wire, which you can see here through the heart. We brought a 6 French sheath or 7 French sheath. Then you used an end snare. We snared. We took out the wire, leaving the graft in place. That is always a little bit dangerous. But then we snared through-and-through 400 Terumo wire, and then having a 7 French sheath protecting the heart with a 7 French sheath, we advanced the stent graft around the corner of the previous endograft that was, of course, being there into the ascending aorta. And then the deployment was, after that, not that complicated. You can perhaps notice that we are here using the short tip endograft of the arch branch device, which is our standard pattern of use, because this gives us also more flexibility to go into the left ventricle without causing any damages to the left ventricle. And then, of course, the procedure moves forward as planned, and then we deploy the device. And in this case, of course, since we had the access from transcardiac approach, we did with the 12 French sheath also the antegrade cannulation of the left subclavian of the left carotid artery, and the rest, as you can see here, with this final result that will come right away. So I will just move forward. And this was the next case that we had. This was an 86-year-old male patient who came actually with a rupture on a Friday night. and he had a mediastinal hematoma. He had a previous thoracic endograft, a previous T-branch in place, also quite difficult to get in. And this is what we had to deal with: type 1A endoleak ruptured, multiple kinks, and anticipated difficulties to go through these angulations. And in this case, again, we did a transapical approach, and you can see here how we were able to navigate the graft through this anatomy with this quite satisfactory final result. However, it's obvious that a transapical approach does not come without any harm, without any risks. And if you look at the data from the transapical TEVAR approach, you see that they have 1.6 higher rate of mortality, which means that these patients are, of course, susceptible to multiple complications. From our experience in 76 arch cases that we've done over the past 5 years that I've been in Munich, most of them branched TEVARs in 53 cases. Some of them also with a short tip. You can see that we only use this transapical axis in 2 cases, which I just happened to demonstrate, but I have more experience in other 2 or 3 cases. It's not something that we regularly do or need to do, but it's something that's absolutely useful to have. So to conclude, the transapical axis is suitable for selected patients. You need to make sure that they have a healthy myocardium, that they don't have a very vulnerable left ventricle wall, which will lead to complications. And one small discussion that I've always had with my cardiac surgeons: is it better to stay with as small sheaths as possible, so just stick to the 7 French sheath and take the wire out, or perhaps even use a larger sheath in order to have more access also to the supraortic vessels. Thank you very much.
Thank you, Nikos. Gustavo, do you use the transapical approach routinely, or is it a bailout option?
I've used only once, Stefan. It was a case that we had a very, very short ascending graft, and I had to use a PMAG. It was an emergent case, so I wanted the stability. I found it to be actually a very stable system. And one question I have, Nikos, is which wire do you snare? I've noticed you didn't snare a Lunderquist or anything braided. Can you comment on that?
I always use the 400 Terumo wire. I haven't found it I think it's, for me, it was always very helpful to be able to change the tension according to the position of the graft and be able to let loose so I can have more space to go around the corner and then have tension when I want to and when I deploy. But this is something that I've been using and not a stiff wire.
I see my friends from the US that are jet-lagged here, and I'm going to ask them, are you using the transapical approach? Do you use only the 7 French sheath to do a through and through, or do you get your devices through that approach in challenging cases? Andy, Mark, Carlos?
Yeah, I have not actually used a transapical approach for the arch grafts I've been involved with.
I don't have that experience either. We were just talking about what wire we use, because Gustavo said why we typically use the 480 Metro wire, because it comes in 021, 025, and 035.
Yeah, actually with the Terumo, the 400 centimeter wire, I had an issue one day where it got really stuck, and I couldn't move it, and it was kind of a problem, so I switched and tried not to use it.
I think the problem with the Terumo wire, if you manipulate too much and you start losing the hydrophilic part of it, and then it kind of starts to get distracted, then it might become a problem. In such a case, I have seen it in through and through wire techniques, but thankfully not in such a case, because of course you need to exchange everything and pull everything back again.
Tomek.
Nikos, congratulations. I have an experience with 3 such cases, urgent situation, but in 2 of them I had an issue with bleeding from this access. Do you have any special advices, or you change something with heparin or anything like that?
Well, that's something which is very important, of course, that you need to work on this, not with any of the cardiac surgeons that you typically work with, but the guy who is doing the TAVR procedures in your institution. I think that's very important, because even the way they do the suturing of the wall is needs some experience in order to avoid bleedings and ruptures of the ventricle. It's not the access that I do personally, so of course we work cardiothoracic surgery, but I think it's important to choose your patients wisely. So they have to be, of course, they're all fragile patients that we have. These are all a little bit older patients, but if you have a patient with private chemotherapy, with a private radiotherapy in the chest, if you have patients under cortisons that you know and anticipate that they're going to have a very fragile myocardium, just let it go.
And I think it's a critical point because I'll show you in my talk later a case that actually went wrong because of that. There's a huge morbidity, and that's why the TAVR experience has moved away from the transapical approach. So I think it's a critical point that you guys are raising.
Excellent, Nikos. Congratulations. My pleasure to introduce the next speaker, Andrea Kalhberg from Milan, who will be talking about cerebrovascular anatomical analysis for preventing stroke during open and endovascular arch repair.
Hi to everybody. Thank you very much, Stefan, Eric, and Jan for inviting me in this wonderful meeting. So, topic is very interesting. It's my disclosure. I want to start with a case. That was a 78-year-old man who came to our hospital in urgency for a symptomatic arch aneurysm with an acute dissection inside it. And the anatomy was particularly because it was a right-sided aorta. The history was hypertension, left atrophic kidney, and this is the preoperative CT scan that shows this right-sided arch, the aneurysm with dissection and intramural hematoma all along the descending thoracic aorta. And if we go into deep in the anatomy, you can see that there's the typical big carotid trunk, also the two carotids arising first from the ascending aorta, and then there's a right big and subclavian artery, and the left subclavian artery is not aberrant, but is coming exactly from the aneurysm. So going too deep into neuroanatomy, into vascular neuroanatomy, we observed that there was an asymmetry clearly between the right and the left vertebral artery, being the latter very small and something like hypoplasic, and dominant the right part. Also, you can see that we identify a possible proximal landing zone in the ascending aorta just below, after the arising of the right common carotid artery. And so we had need to cover both the subclavian arteries. And if we see exactly, the right subclavian artery has the origin of this big vertebral artery just 18 millimeters from the arch. On the contrary, the left subclavian artery arising from the aneurysm has this small vertebral artery coming like 4 centimeters after the origin from the aneurysm. So we decided for revascularization of the right subclavian artery that we will have to cover with a right carotid to subclavian bypass. Then we occluded the left aberrant subclavian artery with an plaster vascular plug 2, and we didn't revascularize the left subclavian artery due to the small vertebral artery, and at the end we completed with the exclusion with 2 zenith alpha thoracic grafts, and you also can highlight the tortuosity of this right-sided aorta that is quite typical. That was the result. You can see the small retrograde endoleak from the right subclavian artery that was revascularized but not plugged, but the aneurysm was completely excluded, was not influenced by the type 2 endoleak. So the patient did well, except for an acute respiratory distress syndrome on first postoperative day, but then the postoperative course was uneventful and discharged on postoperative day 5. So that was an example of what we usually have to notice regarding the anatomy to treat the arch and try to avoid one of the major complications that, of course, is stroke. So we have different techniques for arch repair. Of course, open surgery with adjunctive maneuver of frozen elephant trunk, but also a lot of endovascular techniques, including hybrid repair, parallel grafts, and of course, fenestrated and branched technology. However, all these kind of possible strategies have a kind of mortality, but above all have the risk, entail the risk of stroke in all the different series. So when we are speaking about stroke in arch repair, we have to think that, of course, the majority is still embolic. And in these cases, neuroanatomy is not so probably relevant, but it's more and more important to screen the patient for arrhythmia and do good imaging of the heart, excluding that there's thrombosis on the atrium and the ventricles, to assess the arch and superaortic trunk quality, so identified thrombus ulcers, calcifications, and also carotid stenosis, and of course try to avoid excessive manipulation of the arch or of the superaortic trunks with the surgical cannulas, and try to avoid also air bubbles with careful CO2 washing. But in 26% of cases, we also have some ischemic causes of stroke. And in this case, the evaluation of the neurovascular anatomy should be a key tool in order to avoid and reduce the risk of stroke. And the surgical strategies must be identified that maintain the perfusion of all the identified critical feeders. In particular, when we perform arch imaging, we must take in mind that the most common anomalies include the bovine trunk with 31% of prevalence, but also an independent vertebral artery origin that has an incredible prevalence of 19% of cases. And this, of course, is an important issue, sometimes requires some tailored reconstructions. For example, this case was an acute non-A-non-B dissection with important severe visual malperfusion, coming emergency, and had this particular anatomy with a bicarotid trunk and aberrant right subclavian artery, and also included a left vertebral artery originating directly from the arch. So in this case, the solution was a frozen elephant trunk with a superaortic trunk, customized reimplantation, including the left vertebral artery directly to the aortic graft. But more than the arch anatomy, we have to exclude that there are anatomical anomalies in the intracranial vasculature. In particular, the Willis circle has a posterior communicating artery hypoplasia in more than half of patients, and this could be a risk factor for stroke, and also the vertebral artery terminating directly in the posterior inferior cerebellar artery has a low prevalence of 4%, but is very associated with the risk of stroke if covering one of the subclavian arteries. So all these things must be studied with classical intracranial vascular imaging above all the CTA, but also we have some other methods that should be also used, like time of flight MRI. So finally, there's reports that transcranial duplex ultrasounds may be useful in order to assess the completeness of the Willis circle, and in case it is normal and there's no anomalies, we can perform during arch surgery, during arch open repair, we can perform unilateral perfusion with selective cerebral perfusion through the right axillary artery, but in case we identified some missing arteries in the circle of Willis, it's necessary to perform bilateral selective cerebral anterior perfusion. So also the guidelines strongly recommends that routine preoperative LSA revascularization in case of these anomalies of the neuroanatomy and should be taken in mind with carotid to subclavian bypass or carotid subclavian transposition like we saw also in the previous presentations. So in conclusion, aortic arch repair entails a significant risk of stroke, and preoperative anatomical analysis of supraortic trunks anatomy and intracranial anatomy is very important to choose the tailored and adjunctive strategies to prevent stroke. Thank you very much.
Thank you. Andrea, I don't know which microphone is working. I have one question. We've heard from Gustavo the morbidity of the supraortic trunk debranching. We've seen in your cases that some right vert or left vert that end into a pica are dangerous to co-embolize. But in our practice, you showed that 19% of those vertebral arteries have an origin from the arch itself. So more and more, we have occluded left vertebral after checking that the circle of Willis was perfect and there was no issue. Is it also your practice? I'm asking everyone in the room, are you now selectively embolizing left vertebral that are coming from the arch if you have checked the anatomy above?
So right, this is perfect strategies. This was also we perform now in the last period. We check for the intracranial anatomy and then eventually selectively preoperatively embolize it.
I mean, I do the same, Stefan. I used to not sacrifice these vertebrals, but they are very small oftentimes, and if I prove that there is a good contralateral connection, I think that that's probably the way to go, because it is actually, I think, the morbidity even higher than the numbers I showed you before. In particular, things like Horner syndrome and so forth. You know, you have to dig very deep to do the vertebral bypass.
Is everyone okay with that option, or would some of you always try to bypass or a transposition of the left vert? I don't know, Nikos, do you have a...
So we at the beginning of our experience, we always tried to do it, but we had the same experience with the vertebral transpositions, that they were associated with some significant secondary problems because it would prolong the bypass operation and so on. So now we do the same thing. I have to say that I am not that, and that would be a question to everybody. It would probably be meaningful to have the circle of Willis to know what's going on in every arch case that we're doing. I have to be honest and say that I'm not doing it regularly in all of the cases right now, especially if I do not intend to cover something, but something can always happen. So do you always do it?
So I do it if there is some kind of anomaly like the left vert coming directly from the arch. It is not routine, but it's, I would say, more than half of our patients. I don't know if that's the same. Andy, you want to add something?
Yeah, I have to say that I tend to study all these patients pre-op, but I didn't used to do it.
I think that's if in case we plan to cover the LSA and for some reasons we had not to revascularize it, it should be, I probably do it routinely, the study of intracranial vasculature.
I was just going to ask the group, what is a way in which to establish that the circle of Willis is intact? Because we've sort of moved away from just CT for that based on our neuro-IR input. So I'm curious what your centers consider an appropriate test for establishing an intact circle of Willis.
I mean, I tend to do a CTA. Of course, MRA is, I think, even superior, but for us, logistically, it's a little more difficult to get it, Andy. So we tend to do CTA.
It's the same for us. We seem to be quite happy with the CTA.
Now, how are we going to protect all these vessels, guys? Because, I mean, this is an issue. We certainly have studies that have been done by your group, Stefan and Thilo, with asymptomatic embolies and not even asymptomatic. You know, the rate of stroke seems to be somewhere between 5 to 15% in most series. I think that at some point we'll look towards the past and say, how come we are doing all these cases without cerebral protection?
And let me echo on what you're saying. And do we have better results with open surgery when you're perfusing the brain through the pump? And I mean, when you do DW MRI, you find that
same
also,
rate. I agree.
we also do it the wrong way. So maybe even for open surgery, we need those filters, and there's obviously a way to go. You were quoting the issues we had when opening both carotids when doing those branch cases. The nice thing about it is we could clamp the carotid, so I think it's still the best filter. So there's always a pro and con with every approach. And I think in chronic dissections, when the risk of emboli is usually not that high, we can go PERC. But for those cases you showed, Andrea, with a shaggy aortic wall,
of course, filters may be the option. Yeah.
And
what cardiologists teach us is that probably in normal cases with TAVR, filters at the end were not used so much, but in high-risk cases, of course.
Should we move on,
Yeah.
Stefan? Okay, it's my pleasure to call our next speaker and host, Professor Stefan Haulon. We'll be discussing the challenges of a very trivial procedure, endovascular bento approach.
Thank you very much, Gustavo. Pleasure to be here. Thank you to the organizer for inviting me. Just kidding. So I want to share with you our experience with the endobental. It's still the beginning of the experience, and we've been through major issues, and that's why I wanted to share with you. I'm quoting the Aortic Center, including CT surgeons, cardiologists, because I'll show you that when, this is a slide from Gustavo, when you move into that field of aortic root surgery, you need an advanced aortic program. And in our team, we have involved cardiac surgeons, we have involved interventional cardiology. You need an ICU, and you need a team that is available to perform open and endo cases, including the root. So no limitation when performing open surgery, so you need to select this type of endovascular approach only for patients that are currently really at high risk for an open approach. And on the other hand, if you want to propose an endovascular approach, you need to have a very large experience with fenestrine branch endograft. You obviously need to have access to a hybrid room, and as I was just quoting, have a significant number of branch and arch branch and thoracoabdominal branch cases behind you, because when it goes wrong at this level, it really goes wrong quite badly. And this is an example of a case that went wrong. This patient had a prior ascending graft. When I advanced the delivery system of the branch endograft into the ascending, it actually moved the ascending graft through the valve and ended up with a major aortic valve insufficiency. I had chest pain, but we actually fixed the patient with a TAVR because our cardiology friends were involved in the patient selection. They were okay with the indication, and so we could fix it right away as a team. And this was kind of our first endobental case. It's an open endobental. There's no branches to the coronary, but you see we've changed the valve, we've changed the ascending, and we have on top of that an endo-frozen elephant trunk. So this is the first case where we decided to design an endobental and to brainstorm on an endobental approach for this patient that had a rapidly evolving ascending aorta aneurysm. She had a prior valve repair, and this graft, and you can see also that when they did the valve repair, they did a wrapping, and so the distal ascending is kind of narrowed, so which provided some kind of distal landing zone. And we started using the regular inner-outer branch that we use for our thoracoabdominal repair. Have in mind and take a look at the right coronary. In those cases with root enlargement, most patients have a right coronary that is really upward going. So probably what we learned from that first case, and we learned it by testing the device in a 3D print of the patient's anatomy. So this is the specific patient's anatomy, including the left vert, the coronary arteries. Again, look at the right coronary and the supraaortic trunk, and you can see the final result. It looks good, but we really struggled during that 3D print case and during the real case to access the right coronary and to push a bridging stent inside. So this was the, so that's why from that first design with straight branches, we moved to a second device, and this is a case we performed with Professor Antoine Millon from Lyon. This patient also has a history of a bento procedure, but what we've changed here, look at the coronary branches, we now have helical branches. Those helical branches that were designed by Roy Greenberg for the visceral celiac chunk and SMA target vessel. And we decided that they would perfectly suit the root anatomy. And there was also some cardiac work on this type of repair of the roots a long time ago. And so we changed the design, and also we added the branches for the supraortic trunk because most cases don't have a distal sealing zone in the ascending aorta. So we included those branches for the innominate and left common carotid in a patient that had a prior bypass on transposition. Again, we did a 3D print of the patient's anatomy. You see we have a transapical axis, and that's why I was quoting the transapical axis, because in the end, this patient will actually have major issues because of that. This is the 3D print case. You can see the graft has been released, and now access to the right coronary was actually straightforward, and we used a 018 Viban for the right coronary. Access to the main trunk was also straightforward, and we used a B graft because the trunk was quite short and needed to be very sharp on where I would land that. We knew the best working position, and then we were quite comfortable with the result. Everything actually was very swift, and we were happy with the idea of performing the case using the rendezvous technique, which means apical valve repair and the arch branch coming from the groin. And you can see how both the Bentley stent in the main trunk and the Viban in the right coronary look good at the end of the procedure. So this is the case, images from the case. You can see I'm advancing the sheath transapically over a through and through wire. It was a 4-meter Terumo wire, Carlos, that we used. But now that you've said that, I'm going to maybe look for something else. And then the rendezvous technique, you can see the tip of the delivery system of the branch and the graft has been matched with this sheath for the TAVR. You see that the valve is already in position. And then we started slightly unsheathing the graft. We're checking the position of the endograft and rapid pacing, and this is time to release the endograft once the rapid pacing is working. So you see the rapid pacing probe in the right ventricle. We then released the endograft, which is quite fast. I changed the trigger wire system, only 2 trigger wires to be fast, and then we just advanced everything back through the valve and through the endograft and inflated the valve. So it took about 90 seconds to release the graft and to inflate the TAVR. I'm quoting that because this is one of the main issues, is how long the rapid pacing can undergo and how much left ventricle can undertake. Now you can see that here we have a valve that is working nicely, and we have both coronary arteries that are perfused through their branches, but they're not yet connected. And so now we're through the main, the left coronary branch and into the main trunk. This is just to nicely position the fusion mask. This is my B graft that is accurately positioned. I actually doubled the B graft to change a B graft peripheral into a B graft plus here. This was the 6 French compatible. And then we went into the right coronary artery, which with this helical design was really straightforward on both sides. So this really, although you can see how the right coronary is challenging, and I think what is interesting is to see with the support of the helical branch how the bridging stent actually nicely tracks, which was a main main challenge, major challenge in the prior procedure. And you can see here the right coronary. So at this stage, we have the valve working. We have both coronaries that are perfused. We still have the aneurysm that is perfused because the branches are not connected. We then connected the supraortic trunk and managed to exclude that endograft. And you can see here the post-op CT. So the idea is to propose a minimal invasive repair to those patients, but in the end, is this minimal invasive surgery? Why do I have a question mark? Because the answer was no for that patient. We have to use ECMO because when you release the endograft, long rapid pacing, at one point, if it doesn't work, you need to have that ECMO to get volume out of the left ventricle. So on one side, you have the ECMO in the vein and in the artery. On the other side, you have the delivery system of the endograft. So it's like you're clamping the aorta completely. This obviously was a very high-risk patient, to 82-year-old with cirrhosis, and this is why I was asking Nikos. Our CT surgeon colleague has major issue when closing the transapical access. She lost a lot of blood, went into acidosis, and finally didn't make it out of the hospital. So we're moving forward now, and we are trying to find alternate ways of doing that to avoid the transapical. Again, don't remember, our cardiology colleagues don't use the transapical anymore, and so we're trying to do that with a slightly longer rapid pacing, but with unloading ventricle, the left ventricle, using this percutaneous transseptal, how do you call it? I don't know, I can't remember how do you call this device, the tandem hearts. So we're starting working with this device. We're also starting working on acute type A dissections. We've just submitted this paper on 250 type A dissections, looking at all the various options for those patients that have an acute type A dissection. And we figure out that about half of the patient could be treated with this endo-bental or fenestrated bental option. With the entry tier is distal to the sinotubular junction, and another 24% could be treated with a real branch endobental, which I showed you previously, because the entry tier is in the aortic root. Now, to make sure that this open endobental or fenestrated endobental is straightforward, we've designed, and this is a device that we have an IP on, this free fenestrated device, so you don't care about the rotation, you always have two fenestration in the coronary cusp. So more to come. This is the beginning of the experience. We're starting to treat acute type A dissection. We're starting to have more and more endobental cases. We're still learning, but it's still something quite aggressive, and we obviously need to work together to make it safer. Thank you very much.
Wow, Stefan, this is remarkable. Can you comment a little bit on the choice of the bridging stance? Do you think for the coronaries is going to be more evolving to self-expandable, or it will be balloon expandable?
So I think for the right coronary, currently the self-expandable is mandatory because there's really this sharp curve. The helical branch has really helped the self-expandable bridging stent to track and advance and nicely adapt. But for the main trunk, the issue is that in some of those patients, and most of those patients, the main trunk is quite short. So you need to really use that 5, 6, or 7 millimeter of sealing zone you have in the main trunk. And so far, I think that it's safer to do it with a balloon expandable stent. Sorry. Hi, Thilo.
Stefan, may I ask you a question?
Who's talking?
Yes, Nikos.
Here.
Nikos, yes.
First of all, congratulations on this amazing experience and very, very innovative work. We have a discussion with our cardiac surgeons that we want to move also in our program, and we discussed the option of the rendezvous technique versus the integration of the valve in the main endograft, because we also have the option of a self-expandable TEVAR. So the problem with that they see is that when we go into in the annulus of the heart, the problem is that you pretty much engage the mitral valve muscles, which leads to severe mitral insufficiency in these patients. and they die from that. Do you think that this insufficiency that this patient had could be related to that, or have you had these discussions with them?
Yes, so obviously, if one day we will have a device that includes, and there's been a couple of case reports, handmade branch or fenestrated devices, including a valve. I still believe that for those patients, the balloon expandable approach is the best for the valve, because then you don't need to go too deep into the left ventricle, and then it's actually very stable. You can start on sheathing, inflate your TAVR, and then finish on sheathing. And if it's all in one, then you don't get the issue of the left ventricle that gets overloaded. I think the issue we have is there's one company that has both the valve and the endograph, and it's called Medtronic, but they are not working towards that direction. And the other company are currently separate companies, and it's difficult to get them to work on similar projects. So I think the issue that we're currently facing is that we need a minimal invasive approach, but we don't have the device. But I'm sure that once we'll have it, it's going to become something much easier.
We have, I think we are running out of time.
Yeah, is Tara around? I didn't see Tara Mastracci. She's supposed to speak now. Thilo, do you mind getting a microphone so we can continue? Okay, we'll make a slight change. We will ask you please to show Thilo Kölbel presentation. Thank you so much, Thilo. Sorry, maybe you need that.
Thank you, Stefan, for the stage. It's an unusual feeling to be in this position, but I'm sure we will manage. And I'm very happy to take you back a few centimeters to the left subclavian artery, which of course is a more frequent technique that we all use in our practice, and maybe more relevant for most of us. But I have to say, Stefan, I was deeply impressed to see that case, and I'm happy I arrived in time to see that. Left subclavian artery vascularizations has still a number of not fully answered questions, and that is, do we need to cover the LSA when we do TVAR? When covered, does it need to be revascularized? Which techniques to use, and when to revascularize? I think these are the main questions in LSA revascularization. If we look at the arch and the Ishimaro zones, we actually have to realize that most of our TVAR devices actually land in the aortic arch. And I've looked at in our own series and found that about 80% of our cases actually have a landing in a curved part of the arch. When we look at dissection, it is extremely important that we land in a safe segment of the arch, which usually is the segment 2. And in most cases previously, many operators have been landing distally to the left subclavian artery because this is what has been proposed in the beginning, and this is where the disease starts. But I think we all have made the experience that this is in most cases insufficient because of outcomes, as you see on the right-hand side here. So we've learned that we have to go further into the arch, find safe landing zone, and this usually includes coverage of the left subclavian artery. And this is also true for of course, aneurysmal disease, in which usually zone 2 is not a sufficient landing zone. One view that we not often take when we decide for landing zone is actually this standard axial image. And I'm often surprised how extremely angulated the arch can be in that area. We wouldn't call this a steep arch because if you look from the left side, it wouldn't look that steep, but it has an extreme curve, and you see what this can do to our repair if we land in this angulated part of the arch, that we easily get a retrograde type aortic dissection. So when looking for a landing zone, we need a certain length, we need a certain quality, and this in most of the cases requires coverage of the left subclavian artery. Mandatory revascularization, of course, we have in patients that need supply of the left vertebral artery, that have a dialysis shunt, a Lima bypass, that have a high risk for spinal cord ischemia, as the left subclavian artery actually is perfusing the first intercostal arteries, usually the first two, but also patients secondarily who have developed arm ischemia require revascularization. Let us first come back to the question of vertebral artery dominance. That is a little bit unclear term, but we call it when we see a case like this where one vertebral artery is much smaller than the other, which can be assessed by duplex ultrasound, but also by MR, as you see here. When we see that, we have to be critically aware that a small vertebral artery does not mean it is insignificant. A small vertebral artery can mean that this vertebral artery is what we call an independent Pica artery, so a posterior inferior cerebellar artery. And if you cover this, you almost have a guaranteed severe cerebellum stroke in those cases. And it's not that rare. If you look at this number, it's about 2% of anatomies where you automatically would have a stroke covering the left subclavian artery. Of course, Lima bypasses are not so rare any longer. It's more the rule than the exemption today. And it's easy to miss today because patients frequently are operated also with minimal invasive accesses, as you see here. So you cannot judge from a missing sternotomy wound that the patient may not have a bypass. He still may have that with a small incision. Looking at ESVS guideline recommendations, there is recommendation to revascularize, but you can see that the references there's very little evidence here, and this evidence actually does not support revascularization because of stroke reduction, but because of spinal cord ischemia reduction, which was the only significant finding in this study by Boot from 2007, which initiated that recommendation. So it was originally based on SCI prevention. There's some new evidence on revascularization, which actually is not as strong. And if we look at this meta-analysis from 2017, they did not find a significant difference of revascularizing or not when covering the left subclavian artery, and did not recommend revascularization strongly, although it is an intuitive thing to do. Luckily, we have another, even larger meta-analysis today, which shows in more than 5,000 patients that there is a significant difference. So I think today the ESVS recommendation for revascularization of the left subclavian artery is supported again. So what do we know about this topic? Stroke is more frequent than LSA is covered. Stroke is less frequent when the LSA is revascularized. And we have similar effects on spinal cord ischemia. But there's no data that compares, for instance, the strategy of all versus selective revascularization of the left subclavian artery. No study including complications of those open procedures, and no prospective data. If we look at what techniques are available, we have mainly transposition A and bypass B. Thank you, Gustavo, for the nice images. And we have the endovascular options, which are mainly branched and fenestrated techniques, and I'm sure you have seen some of those devices already here today. Deciding between transposition and bypass, there has been some evidence showing a better patency for transposition. However, it's important to note that this comes from patients with left subclavian artery occlusion, so from arteriosclerotic disease and not from aneurysmal disease. As transposition has a high risk of impacting on the left vertebral artery patency, this has not been studied in those studies. We looked ourselves in Hamburg in an experience of 200 patients with cervical debranching, mostly before endovascular repair, and a significant proportion urgent and ruptured cases, which demands a simultaneous repair. And what we found and what we used was mostly bypasses, as we've always found this being a more versatile technique. And you can see that there was a significant mortality in this group of patients which also received a TEVAR, but that mortality mostly was in the urgent and emergent TEVAR, most probably unrelated to the bypassing and debranching. However, one case in elective where transposition was done. So it's not an insignificant procedure that there's surely a reason to avoid it. We had stroke, quite significant, 4.3%, but mostly in those patients that were simultaneously receiving a TEVAR, so that was probably more TEVAR associated than it was bypass or transposition associated. Complications are mostly bleeding, but neurological complications like Horner syndrome and laryngeal nerve palsy are not infrequent and much more frequent in transposition in our population in Hamburg. So our conclusion was carotid septal claim and bypass should be rather used than transposition, but you can see that the primary patency and the secondary patency was not inferior to what has been reported on transposition in other cohorts. One bypass technology I quickly want to show you is axillary bypass, because I believe this is underused in Europe. We also have a limited experience only of 13 cases, mostly done when in branched TEVAR we could not connect the innominate artery. But what is important is probably mostly that the patency is very good in our experience so far in a midterm follow-up with all of these bypass grafts open. So something to consider. Axillary bypass, very popular in Japan, is something that can revascularize your LSA without any clamp that needs to be placed on the carotid arteries. Please always be aware where the left vertebral artery originates, because it can influence your decision. Here you see on the right-hand side a very proximal left vertebral artery, so there would be no room for landing proximally to it. There would be no room for clamping it and occluding it. And these are all good reasons, in my view, for a bypass instead of transposition. If we do a bypass, it's very important that the bypass is short, proximal, and horizontal. So it's not a standard incision for carotid endarterectomy, but it's an incision that gives you the proximal left subclavian, left carotid artery and subclavian artery, because this is important for your TEVAR and your axis that is following, as in this example, very horizontal, makes it much easier than if you have a left subclavian artery bypass that looks like this, which makes it very hard to get your bridging stent graft across, if that may be possible. One idea that comes from Japan as well is occluding the left subclavian artery during TEVAR. I think this has been not explored sufficiently in Europe. It has shown a reduction of stroke in this population. Carbon dioxide flushing, I'm sure you're all aware of. We have multiple endovascular options to revascularize the left subclavian artery, and you've seen that today here. Not going to go through this. One word about the three inner branch stent graft from Cook and from other companies, because it seems like this is the device to go to revascularize the LSA in arch branch repair. But I have to tell you, in our experience, since we have this device available, I believe we have only used it in a third to half of the patients with arch disease, because I strongly believe that the LSA is not a really good landing zone, because it's quite large, it's often irregular, it's often kinked, and it's easy to get an endoleak from there. And I strongly believe that the two-branched endograft for innominate and carotid artery maybe should be the main workhorse in arch repair, and only a few patients are really eligible for a three-branched repair. In genetic aortic syndrome, there's some additional things to consider, like creating safe landing zones using interposition bypasses, as you see here. And to conclude, preoperative imaging is extremely important in all arch repair. Please be aware of the PICA variant when you look at the images. Don't say it's a small vertebral artery, it's insignificant, it's minor, and you can occlude it. LSA revascularization should be done in most cases. It should be done staged. If possible, it should be done with a bypass, and consider axillary bypass as an option when you don't have another one. Thank you very much.
Thank you very much, Thilo. I have a question for you and for Gustavo. You mentioned the PICA, and I'm still puzzled. What do you do when you find a PICA? Because, I mean, those PICA usually are 1 or 2 millimeters. It's not possible to do bypass on those endograft, or is it?
Usually, first of all, you have to be aware. It's always an advantage to know, because you can better inform your patient about the choices, about the risks that you have. In some patients, you may find a way to do an endovascular procedure landing proximal to it without occluding it. A PICA coming from the arch would be something very difficult to solve, but sometimes knowing it is also an option to stay back from the repair that you're planning.
Gustavo?
I mean, I have to tell you, I haven't come across a case that we had the dilemma of having to occlude a PICA. I mean, it just more like emphasize the importance of revascularizing. But if you have a vertebral artery that is decent size, you can try to do a bypass or a transposition, saphenous vein. But those are challenging, I agree. I mean, I'm glad, Thilo, you're pointing out that at the end of the day, we'll still need to be doing these bypasses and transpositions. So there is, I think, no way around that. Like you said, sometimes the artery is large or is dissected, or you have an early vessel. But on a regular case, do you see that the state is if you can do a branch to the subclavian, that is like the default, is already your standard of care?
So if we have a patient that has a good landing zone in the left subclavian artery, then that is the first choice, because it saves the patient another procedure which also has a significant complication rate. I just wanted to point out that not every arch repair has to be a 3-branch repair, that quite frequently the LSA is 15 millimeter. It is kinked, it is short, so it does not allow landing, but even though it doesn't allow landing, often allows it to be occluded with a plug or with coils. Mm-hmm. So sometimes that's a safer procedure, and it takes away one big step from a complex procedure.
So Thilo, you said, I don't know if I understood correctly, you said most LSAs don't have landing, or is it 50-50? Because in our experience, I think most LSAs are suitable for landing, and I guess a 3-vessel branch arch device can be used. I would say at least in 2/3 of the cases that we see.
Yeah. What I said is, since we have this device available with 3 branches, we have treated only a third to half of the patients with a 3rd branch. Maybe more would have been eligible for it. Maybe 2/3 is correct. But also sometimes I'm quite happy to make the main procedure a little bit more simple. And I find it always simple to do as we always done, like having one branch coming from the left brachial through the bypass and having one carotid cut down. With the 3 branches, it is more complex because you have to decide either for steerable sheath access to the carotid artery or for additional cut down. So there are multiple reasons not always to do a 3-branched.
I think one of the critical points is the bridging stent. So that is probably why some of those cases are not treated with a branch. What is your limitation currently in the US? Because currently, what is the largest bridging stent you can use in Hamburg?
So the largest we use is the Rhapsody with 16 millimeter, but it's an incredibly stiff, nasty device to bring around the corner. So you always have to have a puncture of the brachial artery anyway.
So we have the TBE subclavian branch, which has the problem of being too short. It's only 6 centimeters. I have to say we use it in 2 cases. We actually done it for the nominate from the groin, and it worked very well actually. Which have to use 2 because of the length. But other than that, I think it's a good solution. at least in the US.
Is a good point. With the availability of a better bridging stent, I can agree that the suitability would go up to maybe 2/3. I'm mainly saying this because I see that many colleagues are enthusiastic for 3-branched arch repair, and I think it needs to be pointed out that a 2-branch arch repair still is a great thing to do, and it's not so much to add a carotid subclavian bypass.
That's a good point. Thank you very much, Thilo.